Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for October 13, 2022. Today's CME activity code is 486596. We have a great case today. I'm going to be presenting. Dr. Corbett and Dr. Whittier are both out of town, so we are encouraging everyone else to get as much involved as you can. Put your comments in the chat box. We'll get to them, and of course, our co-hosts can pipe in freely as they like. We have nothing to disclose, and as usual, the patient privacy is preserved. Identifying information, including age, gender, ethnicity, dates, exact laboratory values, and other details have been changed to disguise the identity of the patient and protect the patient's confidentiality. This is being recorded. It'll be up shortly on YouTube. Please join our YouTube channel. I put the link in the chat box, and I also put an email address in the chat box. If anybody wants to get on our email list, we would encourage them. And tell your friends and your other programs, etc. I'll start with this case. It is a 30-year-old white man who first came to Rush University Medical Center complaining of lower extremity edema. He has a long medical history that dates back several years. He has a history of being bipolar and as active intravenous heroin addict. There's a time period for 4 years he claims he was on methadone and was off heroin, but has been back on it for at least a year. He has chronic infections of his lower extremities related to injecting drugs, and all of his prior medical care had been at another hospital. During those hospitalizations, he was diagnosed as having wound infections in his feet with MRSA and was on and off vancomycin for many, many hospitalizations in the last year or two. Looking back at his renal history, his urine had no protein until 2 years ago, which time he had a dipstick positive of 100. We have nothing after that until this admission. His creatinine is recently, and this is despite being at another institution with multiple admissions for infection. His creatinine as recently as 1 year ago was 0.9, but 6 months ago it was 1.3. Again, with no urinalysis. He then presented to Rush University Medical Center for the first time, coming with his complaint of lower extremity swelling, and his creatinine was now 3.2, and his serum albumin was 1.5. And a spot urine protein creatinine ratio was 20 grams per gram. He received IV antibiotics and methadone and was discharged for a follow-up biopsy 2 weeks later. His creatinine at the time of biopsy was 3.6. His past medical history is significant for being bipolar, although he's not on any present medication. And heroin addiction, IV, he does not drink. There's no family history of renal disease. He was out now on Bactrim as a follow-up for his infections and methadone, and he has no allergies. On physical exam, his blood pressure was 130/70, his heart rate was 66. His respiration rate was 12, and he was afebrile. He actually looked pretty well nourished. His lungs were clear, cardiac exam was unremarkable, his abdomen was soft, he had no organomegaly. And here's a picture of his extremities. You can see his legs are fairly inflamed, and there's a lot of lesions on there, and this is a very good example of one of his feet. Both of them basically look the same. On labs, his sodium was 140, his potassium was 4, his chloride was 106, his bicarb was 22, his BUN was 14, and his creatinine was 3.6. Blood glucose 92, calcium 8.3, total protein 6.2, albumin 1.5, calcium 8.3. His LFTs were normal. His serum cholesterol was 240. His CBC had a white count of 11.5, a hemoglobin of 9.5. His platelet count was normal, and his differential was unremarkable of his white cells. His ANA was negative, his ANCA, MPO, PR3 were all normal, his complements were normal, and his PLA2R antibody was negative. He was COVID negative, HIV negative, hepatitis B surface antigen negative, but he did have a hepatitis C antibody detected, and his quantitative hepatitis C RNA was greater than 8 million. His urinalysis had a specific gravity, was yellow, specific gravity 1016, a pH of 7. His dipstick proteinuria was, quote, 600, obviously as high as they can measure on dipstick. 1+ blood, 4 white cells and 1 red blood cell per high power field. His urine protein creatinine ratio, as I mentioned, was about 21 grams with an albumin creatinine ratio of about 10.5 grams. On ultrasound, his right kidney was 14 centimeters, his left kidney was 13.4 centimeters, with moderate echogenicity, and a percutaneous renal biopsy was done by our interventional radiologists. And I think we're going to start with a poll here before we discuss it. So everybody vote. No one will know what your vote is. I want to know what you think the patient's diagnosis will be. Do you think it's A, a hepatitis C related glomerulopathy? Do you think it's 2, an IgA dominant Staph aureus related infectious GN? Remember, he has chronic skin infections with Staph aureus. 3 would be AA amyloidosis, or 4 would be FSGS, focal segmental glomerular sclerosis related to heroin use. Give it a little time. A few more votes here. Don't be shy. The better the representation, the better the discussion.
All right, how about right there?
So a nice response rate. We have 20% think it's hepatitis C related glomerulopathy. A few people think it's an IgA dominant Staph aureus infectious GN. The highest amount are picking AA amyloidosis, and 22% are saying FSGS related to heroin use. So with that, I want to hand this over to Dr. Gashdi. And Casey, why don't you tell us what you think and why any of these fit or don't fit?
So I was thinking along the same line as the polls suggest, that usually when I see a young person who comes in with many year history of IV heroin use, I usually do think of a secondary amyloidosis, especially if they're skin popping, although I'm not really sure if that's a requirement, whether IV heroin by itself could do it. So I do think that number one would be the secondary amyloidosis related to the injection site inflammation or infection. But those legs looked pretty bad and looked very chronic. So definitely an IgA dominant kind of a post-infectious GN from just lower extremity infection is also in the differential. So it's always been interesting to me that we've had staph infections for forever, and we haven't really, this diagnosis of IgA dominant post-infectious is relatively like in the past 15, 20 years that we didn't have this before. And I don't know if this has to do with, being more a higher prevalence of MRSA with resistant to the penicillin antibiotics, or if there's some other factor there. But regardless, an infection related is also possible. Usually those patients tend to have, could have, about 50% of them could have hypocomplementemia. So that's, we don't see that here, but normal complements don't rule it out. You really have to look at the biopsy to see this, but usually that's an AKI that don't give you this degree of nephrosis. That's the part that this doesn't fit as well. I feel like this is more of a nephrotic syndrome. Low albumin, 20 grams of proteinuria. This is really consistent with a nephrotic syndrome, and I think amyloid is probably the best fit. Hepatitis C definitely can give you MPGN type picture, cryoglobulinemia. This doesn't look like cryo to me. This is more of a chronic damage to his skin from whether it's infection or something else, just chronic fungal infections. It looks like the skin is lichenified. So those are possibilities. Again, those are more like GNs. So the elevation in creatinine makes sense. The amount of proteinuria doesn't really fit, although MPGN you can get both nephrotic, nephritic overlap. So that's also possible. And then the last thing on the differential that was there was the FSGS related to heroin use. And I don't know. I mean, it's possible. I haven't really seen a lot of cases of heroin-induced FSGS, so I don't really know what to think of that. I know that there was a description of it in the African Americans who use heroin, but I'm not sure if this is directly related to heroin or if this is, some underlying FSGS sort of like APOL1 thing that this was a second hit on. So putting the whole thing together, I feel like IV heroin user with nephrotic syndrome, it's going to be AA amyloidosis until proven otherwise.
That's great. So does anybody feel strongly about any of the others? Dick, what do you think's going on?
Well, actually, I think the absence of a low C4, even though the patient does have a high level of viral replication, and the relative absence of hematuria makes me think that hepatitis C related glomerulopathy is unlikely. And I would point out that FSGS related to heroin use virtually disappeared from the literature about 10 years ago. Nobody knows exactly why. Maybe people just gave up reporting it, but it has been suggested that the earlier cases were related to brown heroin or black heroin that was contaminated with some other agent that was causing the FSGS, because heroin itself, in the absence of other causes like viral diseases and chronic infections, may not be the factor that induces FSGS. So I would put FSGS related directly to heroin use rather low down, and I think I agree with the majority here of the at least 50%, and this is AA amyloidosis. The cholesterol is interesting, only 240 with a serum albumin of 1.5 and a urine protein of 20 grams a day with large kidneys. I must say that constellation of findings points to amyloid in a very high percentage of patients. So I would bet a case of Brazilian beer that this is amyloid.
Let's just hope the Brazilian beer isn't tainted with black tar, because then we'd be in trouble. I'm really glad you brought up the kidney size. This is not a big guy, and it's interesting, from the waist up he looks very normal, and then you pull down the sheets and it literally takes your breath away how bad these things look. And I asked him, I said, well, what do you do now? He said, well, there's nothing I can do in my legs. And he pointed to a dark spot on right below his clavicle. He says, I have no problem hitting that vein now. It was kind of pretty remarkable finding. And his arms weren't anywhere as bad as the legs. They had some marks on them. At least presently, there was no obvious pus, but it's so hard to discern what's going on here. Is this just chronic inflammation, chronic lichenization from loss of vascular flow from injection, or is it actually chronically infected? It's hard to say. You could always grow something from those wounds, but it's hard to say what's really going on actively with them now. And it brings up what you said and what Dr. Gashti said. When people do inject drugs and they get these lesions, how much of this is inflammation and how much of this is infection? But it really was shocking when I took the sheets off and saw just how bad that was. Anybody have any other strong feelings on the diagnosis? Mario, what do you think's going on?
Well, the only thing I am able to add is that he has significant hyperglobulinemia. And in addition, it's deceiving the UPCR of 20 because 50% of that is albumin. The rest must be globulins. And therefore, with large kidneys and infiltrated disease is a consideration. And I would like to know what the serum and urine protein electrophoresis and immunofixation were.
So you are the absolute king of noticing the differences in either the total protein in the albumin, we call the gamma gap, and I suppose we could call this the protein gap. And always thinking about this, it kind of we see it a lot of times and we think about tubular interstitial, but you're pointing out that there might be a paraproteinemia, and that's a really good point. We did not do an immunoelectrophoresis on him at this time. I'll just leave it at that. So, but what do you think it is, Mario, in spite of all that?
Well, I mean, like Casey and Dr. Glasak mentioned, I think AA amyloidosis is number one.
Okay. Well, with that, I think it's time to spin the wheel. We'll see who reads the biopsy here.
Where is the wheel? Mhm.
Oh, the wheel, maybe the wheel got off. Let me put the
Wheel got off, yep. Wheel's not ready yet.
The wheel had to go to the bathroom.
Yeah.
Zoom.
That is unacceptable. There is no wheel.
There's a wheel.
Can't move on. The show can't go on without the wheel. There we go.
Sorry about that. The wheel was on earlier. I don't know what happened. All right. Oh, great wheel. Who's going to read the biopsy? Tell us with your wisdom. All right, Melanie. Melanie is a second-year fellow. Also a member of the GlomCon GN Fellowship. So pressure's on, Melanie.
Thanks.
I'm sure.
I
I'm
don't
not
think
worried
that was a
about-
nice thing.
I'm not worried about you.
Click on the screen, Mel. Yep.
Okay.
Whoa, laser pointer, nice.
Yeah, see, I'm already putting my new fellowship skills to the test. I know how to do a laser pointer. So here we see one core with the trichrome stain, looking for uptake of the bluish material to indicate some level of chronicity. I don't know, I don't see too many areas of uptake, maybe around here. There's some in this area here as well. Maybe like, I'm not sure if Dr. Simblick is on, but maybe 50%?
Yeah, it's pretty extensive. I mean, there's not many areas of preserved renal tissue here.
Mm-hmm.
As I look throughout the entire sample, it looks quite diffuse. 75%, 90%, 75 to 90%, I estimate.
Okay. No.
Here, I can advance. Oh, we got it. Remember, there's a lag.
Okay, so here we have a high power view. This is H&E stain of the glomerulus. I guess here you can see mesangial expansion in this area here and here, so these segmental areas. The capillary loops otherwise look open. Maybe some hypercellularity in the mesangium in this area here.
Yeah, so does the mesangial expansion look kind of even and symmetrical, or asymmetrical and kind of amorphous?
I would say it's asymmetrical, but it does
Yeah.
look amorphous.
Yeah.
Um,
Yeah, so what does that make you think of what was in our differential?
so leaning towards it, like amyloid.
Yeah. And also the capillary loops look markedly thickened. Look at the one at 7 o'clock. Yeah.
Right here.
Yeah, right there. Yeah. Yep.
So Melanie, if I may, now that you are a fellow of GlomCon, what else besides diabetes and amyloidosis can give you this histological appearance?
I guess diabetic nodular sclerosis would be on the differential, just nodular sclerosis from, like, if the patient had an extensive smoking history and wasn't a diabetic as well, that would be on my differential as well.
Right? If I may add to your beautiful differential light chain, the position disease will do it as well.
Mm-hmm.
How would you differentiate? What stain would you want, Mel? It would
The
help for amyloid at least.
The Congo Red.
Even before that. Hopefully we'll get to that.
Oh, PAS.
Yep.
Yeah, so before you go on to the next stain, also outside the glomerulus at 7, 8 o'clock, there's an arterial with a lot of amorphous pink material. If you could point that out.
Is that here right
Um,
here? Or 7 here? Or here?
Right there, there it goes. Yeah, right there. And then keep going over to the left, straight over to the left. There's some pink amorphous deposits in the interstitium. Yeah, and going up. Keep going up
Oh, here.
right there. Yep.
Okay, so here we have the PAS stain. You can see 2 glomeruli, starting with this one here on the left. Again, you can see areas of mesangial expansion. In this area here, it's asymmetric again. It looks like, I don't know, it doesn't look that like weekly positive. It looks like pretty, I don't know.
Well, compare it to Bowman's capsule, because
Okay,
over
so,
there at 3 o'clock would be normal intensity of Bowman's cap. Yeah,
okay,
keep
so
going.
if I compare it
Yeah.
to like this area right here,
Yeah.
this is much more intense. Okay, in comparison to this. So that's helpful.
Melanie, that was my reaction too when I saw this. It just didn't
Yeah.
look, I thought
Yeah.
that's not that, you typically when we think of amyloid, we think of PAS very weak, and it doesn't seem very weak at all. But I guess David's point is we have to have our compared to what? Compared to our standard or our baseline or whatever. And that's gold standard is the Bowman's capsule, which is much darker.
Yeah, so that was helpful. Thank you.
Yeah.
Um,
And then in the between the 2 glomeruli, you could see, yeah, do you see any areas suspicious for amyloid deposits there? Yeah.
yeah, maybe here
Yeah.
in this area, up here, Dr. Sundberg, would you say,
Mm.
no, I guess that's not, that's more,
Yeah, that may be amyloid. We'll see on the Congo Red, but that's definitely deposition of some material there in the interstitium.
and then here in the glomerulus on the right-hand side, again, you can see the mesangium is expanded, the capillary loops are thickened in certain segmental areas here again.
Yep.
Looking at the tubules, the brush borders they're not intact, so I'd say that there's some injury there. They're a little bit hypertrophied, and there's material inside of the tubules as
Yeah,
well.
little tubular debris. And
Mm.
then over at the far bottom right, there's some atrophic tubules you could see with thickened, shriveled basement membranes. Yeah, over there. Yep.
Oh, wow. Okay, so here we have the silver stain, high power view of a glomerulus. There's a bunch of capillary breaks. This glomerulus looks destroyed.
Well, so yeah, it's just not it's not taking up the stain in this area where there's this amorphous material, but where you can make out the capillary walls, like look up in the middle of the glomerulus. Yeah, you can make some out that are intact.
Like here,
Yeah.
no holes or spikes, at least in that
Yeah.
area, just
Yeah.
these areas of mesangial expansion again.
And then a feature sometimes seen in amyloid is long spikes, described as a coxcomb.
Oh, yes.
And
Let's see if I see that anywhere.
yeah,
David, is that,
Here? Is that,
yeah, I don't really see a coxcomb here, long
okay,
spikes.
no,
Melanie, I had the same impression when I saw this. I see pieces of basement membrane floating all over the place, and I could see exactly why you thought it might have been destroyed. But I think David's point is that it's just there's so much extra matrix here that you're not really catching it.
mhm,
But I get the same impression. I mean, if you really stand back, there's not much in this glomerulus except this amorphous material.
right.
It's kind of filling the glomerulus.
Yeah, replacing the normal structures.
Yeah, thanks, David. Yeah, exactly.
Okay. I'm trying to figure out what stain this is. Is this H&E again?
What color do you see? That might help you. Or what would you like to see for amyloid?
Oh, okay, so this is the Congo Red Stain,
Yeah.
which is not under the polarized light.
Exactly.
Yep.
So if I flip it, is it gonna show me? There it is. So here you
And
see
flip
it.
it again.
Yeah.
There you go.
Yeah.
Okay, so if we go back.
Yeah. So that's the birefringence.
Mhm.
Yep.
Go back to Congo Red and just describe where it's located.
So here, would that be in these areas here? Like mostly in the mesangium, I think.
Yeah. Well, so we have glomerular staining, yeah, mesangium, and I can make out some capillary wall staining also, like at 3 o'clock. Some capillary walls are staining, and then extraglomerular, you have interstitium, tubular basement membranes.
Like in these areas here.
Yeah, that's around the tubular basement membranes, and then up and to the left of the glomerulus is a big blob of a lot of that is interstitial amyloid.
Oh, here?
Yeah, right there. Yeah.
No.
Yeah, I was going to ask David what that structure actually was, because that's a huge blob.
Yeah.
Yeah. I think the lumen is the tubule, and then the rest is all interstitial amyloid. So there's the birefringence under polarized light.
It's a shame Dr. Corbett isn't here, because this is what he lives to see, the birefringence.
And there's mention of a Nicombe prism as well.
What's that? Oh, is that an inside joke?
Oh
No, he just loves to describe exactly the prism and how the prism changes the refractory of the light. And when you go back and forth, you see that they're opposite parallel structure of amyloid.
Okay.
Probably not saying it properly, but he just gets the biggest kick out of that. That's the way we classically, diagnose amyloid, but more and more, we can talk about this later, more and more people are doing, stronger, electron micrograph, I'm thinking blocking the term, not MR, but, staining to tell exactly what the protein is. Anyway, go ahead.
Aspect.
So I guess that's this image here. We're looking at a immunohistochemical stain specifically for amyloid A, which it looks like there's the uptake, which is this brownish color.
Yeah. Oh, that brown positivity is the amyloid. Yep.
Which is kind of, yeah, I guess that's what we would expect to see given his history of the skin popping, chronic infection. That would be the protein being deposited.
That's right.
And this really stresses what David was pointing out in the last slide, how extensive this is, not only in the glomerulus, but in the tubules and perhaps some vessels as well.
Yep.
David, could you comment before we go into the EM on this Texas red filter, which has appeared into the diagnostics tools in recent times?
Oh, I'm sorry, you broke up a little bit.
The Texas red filter as a tool to diagnose amyloidosis?
Oh, yeah, I'm not familiar with that. In our lab here at Rush, we have Congo Red, but stains all types of amyloid. And then to subtype, we have this amyloid A immunostain, and we have the kappa lambda on the immunofluorescence. And then if it's not positive for those, we send it to Mayo Clinic for mass spectroscopy.
Well,
Yeah, mass spec, that's what I couldn't think of. Thank you. Mario, you want to elaborate on that?
basically, here in Texas, but in some other centers as well, they're using these Texas red fluorescent filters. And, basically amyloidosis stains with this method bright red. And according to the expertise of the local renal pathologists, it's quite sensitive for amyloidosis. So you may encounter, particularly for the fellows, this technology in the literature, as well as in some places where you may go to practice.
So is this a stain and a filter, or is it just something on
It's an optic filter.
It's an optic filter, and you don't have to do any special stain. Do they use a PES or a H&E, or do you know?
No, it's just a regular stain H&E, and then they put this red filter in the microscope, and if it lights up all red, it's quite suggestive of amyloidosis.
Oh,
That's that's interesting because that's kind of going backwards. I love the idea. Don't get me wrong. Backwards in the sense that
Careful what you
know,
say about Texas.
no. But David had mentioned MR, where they can identify exactly the molecule, and that's Helmut Reinke was saying that he doesn't even trust Congo Red anymore, or he would not ever stop at Congo Red or anything else. He goes directly to MR. I suppose you do what you have available.
Right. Actually, Helmut uses also the Texas red filter.
Okay, I think I should shut up.
Yeah, so the fluorescence was completely negative, so we'll go to EM.
okay, so here, EMM,
Let's just be very, let's get to the what's important about that. I mean, Dr. Rubin had brought up the possibility of paraproteinemia and several times in the chat. So I think it is important. Sometimes we just say it was negative, but it's importantly negative because we do not have light chain restriction. And I suppose you don't need it when you've got the amyloid A protein, which kind of made our diagnosis. But to be complete, we do not have a paraprotein on immunofluorescence.
so here, we have like a high power view looking at what I'm assuming is like one of the areas that we saw that the mesangial expansion. We're seeing fibrils here, about 10 nanometers in size. I guess there's a range. Some are 13, some are measured at like 9.6. They don't appear organized. Would you say it's like a disorganized arrangement?
Yeah,
Yeah.
good. Yeah. Randomly arranged, non-branching fibrils, and that they could be variable length, but the diameter is on average 10 nanometers.
Okay, so that's specifically the diameter.
Yeah.
Okay, so my diagnosis here would be AA amyloidosis.
Great. So the majority of the people picked the right answer, or at least predicted the right answer, or predicted the correct answer. I don't know if it's right or matter of right or wrong, but predicted the correct answer. And I think for the reasons that were brought up in the discussion, I think that was really for the right reasons, having to do with the differential, as Dr. Gashti had pointed out. Casey, what are your thoughts about this at this point?
Well, unfortunately for him, if this was a Hep C related, at least you could treat the Hep C, but besides stopping the IV heroin use and just the standard of medical therapy with ACE inhibition, blood pressure control, there's not a whole lot you could do to untangle those amyloid fibrils. So unfortunately, this has a pretty poor prognosis. And if you said he's homeless and he's, that none of that is good. So I expect that he's going to be on dialysis soon.
Mm-hmm. So I have another poll here that I want to ask people. It may seem silly, but as I was going through this case, I didn't biopsy him right away, and I really struggled with it, given all the situation. As severe as his nephrosis was, as high as his creatinine was, as and the unlikelihood that if I found anything I could treat it anyway, given his social situation, I really was struggling whether or not to biopsy him. It was not obvious. So I want to see, would you have biopsied this patient? Because it was not an obvious biopsy to me. And on the other hand, and also I'll tell you, when I looked at his legs, to me, it was like amyloid. And we know how that all often backfires. And, we're not out here to guess, but I was fairly certain because we've seen these cases. We've seen a number of them, and they're always, they're always amyloid when we've biopsied them. And as Dr. Glassick said, FSGS, we just don't see that anymore. And with this kind of chronic inflammation. So So I'm watching the votes come in here. We'll let a few more seconds go, and I'll tell you what the mandate is. But it certainly wasn't obvious to me, even though I had him biopsied. And it was also a lot easier, to be quite honest about it, that IR would have the IR ability to help us out on that, because this was not someone who could easily undergo a biopsy. He was. Okay, so we've got about 90% said yes, and only 10% said no. So that's good. I mean, I suppose that's the case, and I suppose that's probably the right answer, even though I did struggle with it. If I could control the screen. So we get back to our poll here, and that's why we had this differential diagnosis in the first place. When I thought about it, there really is a differential diagnosis, even though I wasn't so sure that he needed a biopsy. There was a differential diagnosis. So I want to go through each of these a little bit individually. I didn't take IgA dominant staph related infection that seriously because of the lack of hematuria. So I'm really going to focus on the other three diagnoses.
Roger,
So hepatitis, yeah.
go back to that differential diagnosis slide if you would. There is nothing on this list that is treatable. Of course, the hepatitis C is treatable, but you already know he has viremia, and that would be a sufficient indication for treatment, irrespective of what you find in the biopsy. So the likelihood in this patient that a biopsy is going to specifically lead to a change in management, in my view, is extremely low, extremely low. Now, then you have to say, well, is the risk of biopsy increased in this patient compared to another patient? Well, probably not. The earlier literature suggests that big kidneys with amyloid bleed. That's not true. Big livers with amyloid do bleed. So I wouldn't do a liver biopsy in this patient. But one alternative might have been, and I'd just like to toss it out for discussion, is to do an abdominal fat pad biopsy. If it was strongly positive for amyloid, in this patient, a kidney biopsy is going to contribute virtually nothing to the eventual management of this patient. Now, yes, the intellectual knowledge that he has a disease is certainly helpful in the sense that the doctor's not going to pursue a lot of irrelevant diagnostic tests. But I can't find anything on this list that leads me to believe that a biopsy is going to contribute to a change in management.
So those are really good points. Were you a voter of no biopsy?
Yes. Well, I would have done an abdominal. Roger, I would have done an abdominal fat pad biopsy, which is trivial.
My wow isn't that's it. I just think that's a really good point. Now we've done a number of fat pad biopsies at our institution. And I don't remember anyone coming back positive, but that doesn't mean that it would have been negative. I can't imagine this guy's had so much amyloid everywhere that it wouldn't have been positive. And it doesn't rule out that we could have considered it first. Honestly, it didn't even occur to me because it's off my radar because we've never had one come back positive. But I think that's a really good point because there is nothing treatable. It would certainly be less risk. I do remember the literature on increased bleeding that's now been discarded for amyloid. The thought was, have amyloid in the vessels and they can't constrict and everything else. And as the chat saying, fat pad biopsy is not sensitive. It may not be sensitive, but if it's positive, you avoided a biopsy. And that could have been done easily in the hospital before he went home, as opposed to bringing him back, which quite frankly was quite a task to get him back in for the biopsy and quite an ordeal for the interventional radiologist to actually perform the biopsy. In fact, they called me and they said he was on the table. He couldn't stay steady. They didn't think they got enough tissue. And I said to him, well, thanks for trying. I said, fortunately, what I think he has, we only need one glomerulus to diagnose. And he said, well, that's good to know. And lo and behold, even though he barely got any tissue, he had plenty of glomeruli to make the diagnosis. But I think those are really good points, Dick. And that would have been an alternate approach. Let me go through each of these. So hepatitis C, this is a review. And, you know, for those of you that aren't quite as old as me, there, if you look, the first two diagnoses here, cryoglobulinemia with or without MPGN, and MPGN. And, you know, when I was a resident, there was no hepatitis C. There was no way to tell. It was non-A, non-B hepatitis. There was no way to diagnose people that could have a hepatitis C related problem without elevation in their liver enzymes, which of course so many of these hepatitis C patients have. They don't have active hepatitis, but they're carriers. And so what we had was a disease called idiopathic cryoglobulinemia, and it looks just like we know now. It's just we didn't have the diagnosis because we didn't have a way of telling that. And the same thing, we had idiopathic MPGN in adults. And then once we got the test that was no longer non-A, non-B hepatitis, and we realized this was hep C, they went back and looked, and sure enough, most patients of idiopathic, and prospectively, most patients with idiopathic MPGN or idiopathic cryoglobulinemia had hepatitis C, and it changed everything because at some, you know, we had to decide, are we going to treat the hep C, or are we going to treat the inflammatory response to the hep C? And initially, we did not have treatments for hep C, so we were still treating the inflammatory response to the immune complexes. But now that we know it's hep C related, and we have really, really good treatments for hep C, the whole approach to these first two have changed, as both diagnostically and therapeutically. And we don't typically give a lot of immunosuppression unless it's so severe that, like an RPGN, and we don't want to wait for the antiviral to work, or we'll do Plex on top of it if we have a cryoglobulin circulating or something. The paradigm has completely changed in my career. And the only reason what I circled here was non-cryoglobulemic membranous, or basically hepatitis C related membranous, which I don't even, quite frankly, know if it exists, because I kind of threw both these out as people put in the chat, and Dr. Glassick said, and Dr. Gashey said, you know, the complements are normal, the urine's benign. This is not a typical presentation. This was a nephrotic, almost pure nephrotic, not a nephritic presentation, which you'd more expect with MPGN or cryoglobulinemia. So if I'm going to blame this on a hep C disease, I would think about membranous, and there really isn't a lot written about that. And you know, hep C is very common. So when you see membranous with hep C, it's hard to necessarily associate it with when you see membranous to associate with the virus itself, and they may be coexistent. Similar thing with the literature of non-steroidals associated with membranous. I'm not so sure that's a real association because so many people take non-steroidals. You know, I went and looked a little bit more about, you know, what I could find about hep C related membranous, and I found very little actually. You know, I found this paper here, and they just described, quote, several cases. Well, you would think that if this was that strong a relationship, you wouldn't have to have several cases. And they said what we already said. One of the things clinically is that the complements are normal. They'd have a negative rheumatoid factor, negative cryos, and the urine is be pretty benign. But I don't know. I'm not convinced that hep C and it causes membranous. What do you guys think, Dick? What do you think that hep C causes membranous?
It must be very uncommon, Roger. Most of the patients that I've seen who have membranous and HCV also have HBV. And co-infection is fairly common. So I think when you see a patient with HCV positivity and membranous, you should do an HBV test, which is
Yeah, well, I think
most often
I'm glad
done.
you agree, because it just seems like it's probably maybe just an epiphenomena. So, but that was kind of my impression. If it was really, there's a lot of hep C, and if membranous was out there, we wouldn't be dealing with it a case here and there. So let's talk about the history of heroin-associated nephropathy, and this came up both in discussion and very nicely in the chat. And this is the first one, came out in 1974 by out of New York. And I think the interesting thing was what they're describing here is FSGS, and this was alluded to by several people that, you know, this is 14 Black heroin addicts in New York City that ended up with this very nephrotic syndrome, not just proteinuria and renal failure, and they had a segmental scar here, that's a segmental lesion. It is pointed out, though, that there was, you know, that there was some hypercellularity, and it makes me kind of think about what Mel Schwartzford first described was the cellular lesion of FSGS, and later kind of turned into collapsing FSGS. And 1974, collapsing FSGS was not a diagnosis. Didn't come till much later. But you have to wonder, being 14, they're all black heroin addicts, and of course, it's not limited to that race in New York City by any remote imagination, that maybe this was one of the first descriptions of APOL1 related renal disease, and that the heroin, as is so many things with APOL1, becomes a second hit. And it's a little bit suggested by the epithelial cell proliferation here. It's just a thought. It's not unique. People brought it up several times in the chat and verbally, but I think it's kind of interesting, at least. And I don't know. Dick said we don't see this anymore, and I don't know why. Is it because of the contamination or not? And we're going to get into that. Then in 1979, this actually came out of Rush, and Dr. Lewis with Kathy Meador, who was, I think, a fellow at the time, and Zev, one of the early attendings, Zev Sharon, wrote this paper of renal amyloid with subcutaneous drug abuse. And they had two patients that were skin poppers and developed amyloid. This is a black and white of a Congo Red. And so you can't really tell, but it's positive, and not a great EM, but these are all fibrils associated with amyloid. And so that's kind of where we were for the longest time, and more AA amyloid kind of replaced the heroin related FSGS association. And then 39 years later, this comes out in JASN, and with heroin use that became almost epidemic in the Pacific Northwest. Now, they were describing actually black tar heroin, and that was the question now. Is it a contaminant or is it the infection? I would like to point out certainly that AA amyloid now in this population certainly was not, there was no race association. Most of these patients were white. And that would make sense because we're not talking about focal sclerosis here. We're talking about AA amyloid. But apparently that this was a very common contaminant there. And it kind of does question whether or not how much of this is infection versus a contaminant. When you look at their patients here, the highest risk factor, these were heroin users, and they compared it to kidney biopsies of a bunch of control patients you can see here on the right, with had a whole number of other lesions. But heroin use was the predominant association of the AA amyloid. Recent use had the strongest odds ratio, 220. So recent heroin was very strong. And unfortunately, we don't really know if it's not associated with, if it's just associated with intravenous use, because they didn't really break it down here. They can tell you what percent were intravenous. They were all, the majority were intravenous users, but as far as injecting your muscle or skin popping, we don't really have a population that only injected in the vein without popping their skin or getting it in the muscle. So it's difficult to say, again, if this is a contaminant or infection. And if you look here, skin abscess was, the majority of patients did have skin abscesses. So we really don't know. I mean, when you look at this guy's legs, how much of this is, and I don't know what kind of heroin he had, and it doesn't have to be just black tar heroin. I'm sure that heroin is very contaminated with a lot of things. And there's a lot of being injected, and I can see how either of those could be the cause. I'm not sure how we'll ever tweak out whether or not it's a contaminant or a chronic infection. What we do know, and that was alluded by Dr. Gashti, is what a terrible prognosis these patients have. And this graph basically is, they had two graphs. It's the same curve. One is that the percent that develop ESRD is about 50% at 5 years, and the proportion surviving is about 50% at 5 years, compared to the control GNs, which are the numbers here, which again is no surprise. This is, it's hard to say how much of this is because it's the point of no return, or just the fact that heroin addiction is a really terrible thing and people can't get off heroin, and they continue to inject. And it was kind of clear for my patient that this was going to continue. We had a long talk just to kind of give him some hope about what dialysis would mean, and to him, even if it were possible, he's homeless. It's just a disaster. The whole thing is just really, really sad. And you go in this room and you think, well, this is all brought upon yourself. And then you realize that this is, and I'm not a callous person, but And I don't generally have that, but I left that room being so empathetic for this poor kid who's basically addicted. No matter what you say, he's addicted to drugs, and it's not going to change. It's been his whole life, and I don't see how he can possibly have a prognosis going to be. This would be a good prognosis for him, and I don't think he's going to have that. Really, really, really quite sad. There's a nice article that came out a few years ago also that basically kind of alludes to what I was saying, that the changing spectrum of heroin-associated nephropathy over the years, from focal segmental glomerular sclerosis, much more to amyloidosis now, as Dick alluded to. And of course, there's all this is here, the nephritic and a KKI, but that doesn't really fit our case because he presented with nephrotic syndrome. This is his course. His creatinine when he came in, it got a little bit better. This is when he was discharged. His biopsy was done somewhere about here. Then he came in about a month later after the biopsy, feeling very poor, and we were all ready to dialyze him. Here's actually his albumin was below 1.5, and it went up to almost 2.5, and that's probably because his renal function got worse. And then as his renal function got better again, for whatever reason in the hospital, his albumin started falling again. And we offered, we talked to him about dialysis here, but he actually got better enough that that he decided he didn't really want it, and it really wasn't indicated at this point, but it's pretty inevitable for him that that's going to happen. And, I don't even know what to say about putting a catheter. He's not going to go do PD. I don't know how he'd even do hemo. I don't know how he'd get there. I don't know. The social workers worked with him and gave him where he can go to get some living situation and everything. But I'm just so pessimistic. It's really don't know what else to say, and be curious what other people's experiences along that line. Dr. Glassick says, would we consider doing a medical nephrectomy? Well, I think that's not out of the question, although I think with his renal failure, it's going to move up so quickly. I believe his albumin is going to come up pretty quickly. I think he's got a fairly fast trajectory to end-stage renal disease, and I think it won't be long before he comes back. When you look at where his creatinine was about a year ago, it was 1.3, and now it's 4 to 6. I don't think that's going to be necessary, and even then, it doesn't solve the problem of dialyzing him. I really don't know, what's going to happen for this poor guy. I think he's going to die, and he's going to die not a good death. Dr. Glassick says he actually does say that sensitive fat pad biopsy amyloid in patients with large kidneys is quite high. So I don't have the experience, and it could be our lab. So regardless if it's high or low, I think it's a great idea, and it might have avoided the risk of a biopsy and something we could have done earlier. I don't think it changes anything, but I think that should be added to our thought process. Casey, what do you think? Would you even think about offering dialysis, or you think?
Well, I was thinking about Dr. Glassick's question about doing a nephrectomy. Is that to get his albumin up? Is that the thinking?
For nephrosis. Yeah, for nephrosis, yeah. I think.
Yeah. I don't know. That's a tough decision. I feel like if you do a nephrectomy, he'll be on dialysis now. You basically drop his residual function down to 0 immediately. Is that a good thing? Gets his albumin up, then it essentially becomes a nutritional thing. I don't know. I mean, socially, this guy, like you said, if he's homeless, it's going to be really tough to even put him on dialysis. Where is he going to go? And there's just so many social factors with his drug use and everything. So it's a really tough question. I don't have an answer to.
Yeah.
Would I put him on dialysis? Same considerations, right? Putting a catheter, his veins are all shot, right? He obviously has no place to go. That's why he's skin popping. So
well, he's able to shoot actually right here, right in his neck. So I have a
right?
feeling you could get a line. Yeah, I think you get.
If you get a line in him, then that's kind of a direct port for him to put his heroin in, and then you're dealing with infections, and all of this is not good. I mean, at some point you may not have a choice. You may have to put a tunnel catheter and put him on dialysis and deal with the social situation however you can. But I'm trying to think what would be the best modality for him. I mean, being homeless, I think put PD and all that stuff is out of the equation. So you're really stuck with a catheter and in-center hemodialysis wherever he wanders, I guess, that in that geographic region.
Yeah, I don't see it happening, but it doesn't mean when he comes, we'll have to deal with that problem as best we can. In the chat was, some questions about cardiac amyloid. I remember when I was a resident, I was taught, I think it's wrong, that secondary amyloid doesn't affect the organs, the big organs, as much as primary amyloid. I don't think that's true. I was looking it up this morning and couldn't find anything to support that. But I don't know if he has cardiac involvement. I don't know if he has liver involvement. As much as his kidneys are involved, you would think he would. We did not do an echocardiogram. It was kind of a simplistic approach. I don't know what we would have done with the information, but that doesn't excuse the fact that he may have significant cardiac involvement. He didn't have clinical cardiac involvement, but sometimes they can have a restriction or a dilatation. They can have arrhythmias and all kinds of things. So involved palliative care. I mean, obviously that's probably where this is going to go. But this poor kid, he didn't have any idea what was ahead of him. He wouldn't have let us do a nephrectomy, but that's neither here nor there either.
Outside of the social situation, I'll take that outside, take the whole, follow-up. Anticoagulation would be something else. I mean, it really.
So we sent him home on Eliquis, but I don't know that he ever got any more of it than what he had. So, but I think I think he's at a huge risk, and I think that's a really good point that shouldn't be overlooked here. I think he got his
Roger.
method. Yeah,
Roger. I think the likelihood is that this patient has concomitant hepatic amyloidosis. With this amount of amyloid, with the relatively low cholesterol, with the severe hypoalbuminemia, I think he almost certainly has hepatic involvement. That makes no difference in terms of management, but it does make me a little bit less enthusiastic about a medical nephrectomy, because if he has profound hepatic involvement interfering with albumin synthesis, some of this hypoalbuminemia is not related to urinary losses. It's due to hepatic synthetic capacity. And in that sense, hypoalbuminemia due to liver disease does not increase the risk of thrombosis. It's only in patients who have hypoalbuminemia from renal losses, and even then, only in patients with membranous as opposed to the non-membranous lesions. I know of no evidence to indicate that there is a hypercoagulable state in nephrotic syndrome due to secondary amyloidosis. So I would be, obviously, I would not put this patient on prophylactic anticoagulants.
Well, we've seen patients with minimal change get thrombosis, and we've talked about this in conference.
Yes, but how many patients have you seen with secondary amyloidosis who have died of massive thromboembolism? I must say, I can't recall a single patient. I would have to go back to the literature and see, but there are many patients with massive proteinuria are not at increased risk of thromboembolism. FSGS, for example, can have proteinuria of this magnitude, yet the risk of thromboembolism is very low. I'm just trying to make a point that the hypoalbuminemia in this patient, I think, is complicated by the fact of likely concomitant hepatic secondary amyloidosis. I can't prove that, but I would certainly bet that a CT scan will show hepatomegaly. I don't know, I wouldn't do liver function tests. I mean, testing for it will make no difference in the management of this patient anyway. Roger, I did do a quick literature search a little offline, and the sensitivity of fat pad biopsy in patients with proven secondary amyloidosis is 90%. So those who would discourage a fat pad biopsy based on low sensitivity, I don't think are using the right database.
Along those lines, Roger, did you guys consider doing a skin biopsy of the leg process? I wonder if there was amyloidosis there.
No, we didn't. there's probably at the other institution, they certainly did, when they were treating it, they were taking it, but no, that's interesting because you wonder what's forming all that foot,
Yeah, right.
Yeah,
Anyway,
maybe that's even more sensitive. It may never heal, but yeah,
well,
man, that's a good point. That would have been fun to do.
the other thing is I place in the chat a link for those interested in what amyloidosis looks with the Texas Red filter. You just click in there, the image will come right out. And I also placed the reference, which is in the current opinion in nephrology and hypertension, for more information on the subject.
Yeah, I saw that. That was nice. I'm colorblind. I was still recognized how nice that slide was. So that tells you how good that picture was that you sent. Amyloid's such an odd thing. I mean, a diagnosis that's based on a stain, yet there's 30 different pathophysiologies for it. Some of them have multi-organ involvement. Some of them are very specific to just localized. About 2/3 of them are just localized to certain tissues. I mean, the more common ones that we're used to are AL amyloid, AA amyloid. We see some AA amyloid in Crohn's disease, TB, other chronic infections, etc. Osteomyelitis. In fact, I've seen a lot of AL amyloid in patients who've had gunshot wounds, and they're not necessarily in the best environments. They got chronic sacral D-cubes and osteomyelitis, and they get nephrotic, and that's been more common than skin popping in the patients I've seen with AA amyloid. We see AA amyloid in our dialysis patients from beta-2 microglobulin, ALEC2 amyloid, which is another complete different diagnosis, and more of this transthyretin diagnosis that the cardiologists are making. They all have the same name as amyloid, but they're very different pathophysiologies. I can't think of anything else in medicine that has a name based on a stain, and yet so many different pathophysiologies. That I don't know if that's a good thing or a bad thing. I mean, it helps us to have some sense of nomenclature, but I don't know if it's a good thing or a bad thing. But I can't think of anything else in medicine that's so crazy as that. If unless anybody else has any comments, I'm going to wrap this up. Thanks, everybody. That was a fun discussion. Odd case, very sad case, but I appreciate everybody's opinions, and I learned a lot in talking about it. So thanks. Stay safe till next week. We should be on next week. Let us know if you're not on our email list, and we'll send you we'll put you on the list. We'll include you. So take care, everybody.